Our next speaker is Dr. Paul Torrens. And when Paul found out that we were giving this symposium, he was very kind to volunteer to be one of our speakers. And so I went to his office and I said, Paul, the theme is the epidemic of chronic disease, and being a health services delivery guru, and he wrote the book on it. We started talking for a bit, and he said, you know, the big problem I see is that we really have a health system that's set up for acute care. We're not very good at providing for chronic disease prevention and control. And so he said, that's what I think I should be talking about. And so that's what we agreed on. The name of his talk is going to be A Chronic Disease Agenda for Healthcare in the Developing and Developed World. And I mentioned that he wrote the book, and he did write the book. He is really a premier scholar on the issue of health services and health services organizations and financing healthcare. Theory, managerial processes in service organizations and managed care. He has worked not only in this country, but in a dozen and a half other countries. And so we're very honored this semester that he is teaching our course on comparative health systems, and it's been a real treat for our students. Dr. Torrens received his MD from Georgetown and MPH from Harvard. He was initially a clinician, had a long career in two areas of healthcare management and healthcare policy, and I'm very delighted to have him speak to you today.
Thank you very much. I'm very uneasy about speaking after the two presentations that you've had. To have the president of the university summarize things so well, and to have Dr. Lee make such an excellent presentation. If I had any sense, I would just say, let's rerun those two, and I would sit down. But as many of you know, I'm not a person to use good sense if there is an alternative available. So I'm going to push on. But I do want to say that it was really fascinating to hear the president summarize things so well. And Dr. Lee, you make such an interesting presentation on what's happening in China, very valuable. My presentation today, I'm not an epidemiologist, and I'm not a researcher so much. I've been much more involved in the management of health systems and health policy. And so I'm going to look at things from the point of view of what the change in disease patterns means for healthcare, and what healthcare has to do to adjust to those changing disease patterns. And you'll see where we're going. I'm going to just make several points, and I'm not going to use slides because I'm first of all going to watch the time, because I know if I don't, my colleagues on both sides, there's a trapdoor up here that will disappear. But more than that, I want to give you a chance to discuss. But it strikes me that the purpose of this meeting is extraordinarily timely and important. The importance of chronic disease and the burden of illness around the world is growing rapidly and is shaping the health of people all around the world in ways that infectious diseases did at the early part of the century. It is the most understood and underappreciated change that has taken place. It is seismic in nature. And the first point I want to make is, that first of all, to congratulate Andy and Paula and the school for putting on this. But this is a seismic event that is taking place. It's not a minor series of events. It is a major change in everything, as I hope that you will see. My purpose also today is to call attention to the need for change with regards to how we all look at illness and diseases in general. The key message that I want to get across is not so much public programs, as Dr. Lee has covered very well, but the sense that the model of illness, and therefore the model of the service system, needs to be revised, and the major change that needs to take place is how we as healthcare professionals look at health and illness these days, there is nothing less than a fundamental change in understanding of the pattern of illness, and it's important to everything in the world. So the key point I would like to make today, if nothing else sticks, is the major change are not individual programs, which are terrific, but the thinking that healthcare people have about the model of illness, and we'll come back to that. What is the evidence of the importance of chronic illness in general health, and specifically about health planning around the world? I would simply bring to your attention two pieces of evidence from journal articles within the last month or two here in the United States. The first is a New England Journal article, New England Journal being a major American clinical journal and around the world, and in March 25th issue, just a month ago, major article on the prevalence of diabetes among men and women in China. And so all of a sudden, here we are having from the China National Diabetes and Metabolic Disorders Study Group pointing out to us the impact of chronic illness, and particularly diabetes, one illness, and published in an American journal, and in a way saying, look folks, let's learn from China what's happening, because it's also happening in the United States. The idea of the importance simply of diabetes as one chronic illness. The other article that I would mention to you, more in my area, is from the Journal of Health Affairs, April of this month, April of this year, less than a month ago, by Ken Thorpe and colleagues at Emory, talking about chronic conditions account for a rise in Medicare spending from 1987 to 2006. The abstract summarizes it very well. Medicare beneficiaries' medical needs and where beneficiaries undergo treatment have changed dramatically over the past 2 decades. 20 years ago, most spending growth was linked to intensive inpatient hospital services, chiefly for heart disease. More recently, much of the growth has been attributable to chronic illnesses such as diabetes, arthritis, hypertension, and kidney disease. These conditions are chiefly treated not in hospitals, but in outpatient settings, and by patients at home with prescription drugs. Health reform must address changed health needs through evidence-based community prevention, care coordination, and support for patient management. So here is an article primarily about the rise in healthcare costs in the United States, coming from chronic illness, and talking about the change of locus of care. And remember that, saying locus of care, primarily with regard to cost, used to be hospitals. Now we're caring for people with chronic illness out of hospitals and at home, and we'll come back to that. So that the evidence for the importance of chronic illness, not just in China, but in the United States, and for the rise in healthcare costs, is very clear, and will become more evident and more powerful as time goes by. Now, why should we be concerned about these trends, and why should we actively think about the needs for change in the way healthcare is organized in this country and around the world? I would put it to you that the importance is because the models of delivery of services and the needs and of financing are based on an older model that no longer is adequate to meet the needs of today's population with chronic illness. The point I want to make here is that the models of delivery and of financing basically were set in this country before World War II. And when the pattern of illness was the acute illness model, a series of separate events that had a clear beginning, middle, and an end, that did not require continuing attention in the period between illness episodes, and it was financed on an item-by-item of service for each episode of service or illness. The development of this model was paralleled by the growth of the hospital as the then new center of science, medicine, and technology, and it reinforced the model of high technology, institution-based, episodic clinical care. Illness was seen then as a series of discontinuous, somewhat episodic events, and therefore an episodic, discontinuous system of service and financing was quite appropriate for that model. It was quite appropriate for that model at that time, but as financing came in a certain way, it systematized and concretized, if you will, that model of episodic care. I want to suggest to you that that model is no longer helpful and in fact is probably damaging to the idea of taking care of chronic illness. So that the major point I would make is that the model of thinking, the model of care that we've become used to, no longer is appropriate. And I've mentioned few reasons why, but if you take nothing away from the session, I want you to think about our entire model of care, our entire model of financing is based on a series of epidemiological events that no longer are the critical ones. And so we have to make a transition, not in terms of the epidemiology, that's already taken place, but in terms of our thinking. The model of illness today is quite different from the model of illness in that period before World War II, when our system of care and system of financing was set. The model of illness today begins early in life, before we know it. It continues long-term throughout life, and it requires non-institutional interventions of a different nature. It requires a model of delivery and financing that is long-term and continuous in nature, that focuses on prevention, on early detection, and limitation of disease impact. It requires nothing less than a complete rethinking of how we educate healthcare personnel, how we organize patterns and programs of care, and how we finance this entire effort. I cannot stress enough about the importance of how we finance care shaping how we deliver care. An addendum to this general discussion of chronic illness, I would also mention very briefly the growing challenge of mental illness, and particularly of chronic mental illness. If we think there is a growing epidemic of physical chronic illness, I would strongly urge you to include in your thinking the growing awareness of the impact of chronic mental illness as well, because in the future that is probably going to be even more critical than many of the physical issues, physical health issues that we're dealing with today. Is there a possibility of change in how we think about this growing epidemic of chronic illness around the world? I would suggest to you, am I sounding like a preacher? I have a brother who's a Jesuit priest who does a lot of preaching. If he hears about this, he's going to start to practice medicine, which would be dangerous. But it is important, and I am passionate about this, obviously. The first step in dealing with the chronic illness epidemic around the world is the clear identification of the problem and the challenge. And this is why this conference is so timely, and why the presentation of Dr. Lee and others is so useful. It makes it very clear what is happening. The second step is to begin to develop new models of intervention in the disease patterns and processes, and to learn better what works well and works in which society and under which circumstances. and that period of experimentation of new models of approaching this burden of chronic illness is critical. But the third will be to develop broad public support for new models of care and to develop those delivery and financial models in a way that covers the population in a different sense or a different pattern of illness, so that there is several steps, one of which is becoming clear. What is the burden of illness? Number two, what works? Number three, health policy that finances and reinforces and reshapes the delivery system. I would point out to you that as an example of some of these beginning changes that are beginning to take place, I would bring to your attention one of the most important sections of the recent healthcare reform legislation that has been passed in this country, but one that has received very little publicity and attention. It introduces a new way of financing healthcare services at home for people with chronic illness. It's called the CLASS Act, C-L-A-S-S. This is Clinical Living at Home Support Services, Community Living at Home Support Services. And it was something that Senator Edward Kennedy was championing at the time of his death. Fortunately, Senator Max Baucus, when Senator Kennedy passed away, took the CLASS Act materials and included it in healthcare reform, and it has continued. It's included in the broader healthcare reform legislation and provides a means of better financing for care for people at home with chronic illness. If you would have asked me 2 years ago or 1 year ago whether we would be thinking about new forms of long-term continuous financing for services at home, I would have said to you, no chance. Now, whether it will survive in the healthcare reform legislation or not, I'm just not sure. But it is a beginning of looking at how we finance and how we deliver care, rather than having people go into nursing homes by default because there is no alternative. This mechanism provides a way of financing for the delivery of care of people at home. It's a beginning, and it may not be the right beginning, but it is a beginning. I simply would like to summarize at this point and to tell you that what I think we need to do is to take the information provided by studies like Framingham, Dr. Lee's study in China, understand the tremendous impact of illness of a chronic and continuous nature, and learn from it, experiment in the development of new programs of delivery of services that are preventive, predictive, and continuous in nature. And then at some point, take this and change the paradigm of education of clinicians, of public policy and public thinking, and particularly financing of care. We are at the cusp of what should be a major change in the organization of health services and its financing. And if we have sense, possibly we'll come back 5 years from now and have another program here that will talk about new developments in financing and delivery. The identification of the problems are necessary and the first step, but they are only the first step. The more important changes are how we think about healthcare and illness, what we develop in the way of systems of organization and financing. Thank you very much.